Good evening, everybody, and thanks for taking time out of your evening to join us tonight. My name is Brenda Moynihan, and I'm the Director of Marketing and Outreach here at the Kensington Assisted Living Residence. And tonight's presentation is Understanding Pelvic Floor Health in Women, Regaining Your Comfort and Confidence, Part 2. I do have to apologize to everyone because we did have part 1 of this presentation a few weeks ago, and we did record it. Unfortunately, the recording did not set, and we don't have it on our website, so I do apologize. And before I introduce our speakers, just want to give you some very brief information about the Kensington for those of you that are new to our community. So we are an enhanced assisted living, and we're located in White Plains. We have a full spectrum of clinical support, including caring for those with Alzheimer's and additional dementias, and those with moderate to very high care needs. If you have a loved one and you're searching for senior living and like more information about the Kensington, please feel free to call us at 914-390-0080, or please take a look at our website at www.thekensingtonwhiteplains.com. And if you've got questions, please hold them to the end, and please feel free to type them in the Q&A box. So now I'd like to ask you to join me in welcoming our speakers for this evening, Dr. Svetlana Lozo and Nirupama, also Niru for short, Somasundarama. And let me read you their bios. Dr. Svetlana Lozo is board certified in obstetrics and gynecology and some subspecialized in female pelvic medicine and reconstructive surgery, urogynecology. Dr. Lozo completed her fellowship at University of Chicago and North Shore University Health System. She provides patient-centered medical and surgical care for women with urinary and bowel incontinence, pelvic organ prolapse, fistula, and pelvic floor trauma. Minimally invasive surgical practice are vaginal, laparoscopic, robotic, and cytoscopic. Welcome, Dr. Lozo.
Thank you.
Nirupama Somasundaram, and Niro for short, is a nurse practitioner board certified in female pelvic medicine and reconstructive surgery. Niro has expertise in the areas of abnormal uterine and vaginal bleeding, female pelvic organ prolapse, female pelvic pain, female pelvic surgery fibroids, and much, much more. Welcome, Niru.
Thank
Niru,
you.
you're on mute. So my wonderful presenters, I am actually going to turn off my camera and put myself on mute, and I'm going to hand it over to these excellent ladies.
Okay, I'm going to start sharing our slides and hope everybody can see them. Thank you, Brenda, for such a lovely introduction. We're very honored to be here with everybody tonight. Niru and I are lucky that we work with a lovely team of physicians at Columbia. Here in our picture, it's Dr. Ladini Terry Kaplan and Dr. Hilai Hasham, who also part of our team, but could not really join us tonight. What we're gonna start tonight is we're gonna do a little short presentation about some of the conditions that we treat and procedures that we do, and then we're gonna open the floor for some questions. So I'm gonna start with discussion of the fecal incontinence, which is known as accidental bowel leakage. It is involuntary loss of solid or liquid stool. Most of the patients who experience these symptoms are not comfortable talking about their problems. They're embarrassed, they're ashamed, they feel that their body should not be doing this. However, as we all age, the possibilities of this are occurring. 2 to 25% of women as they age develop fecal incontinence. Some of the risk factors that we notice for fecal incontinence are increasing age, female gender, history of smoking, and history of obesity. When we look at the gastrointestinal factors, there's a multitude of gastrointestinal conditions that can lead to fecal incontinence. Some of those are conditions like IBS, which can lead to loose or watery stools, frequent bowel movements, rectal urgency, or inflammatory bowel disease. When it comes to obstetric history risk factors, we have pregnancy, we have a pelvic floor trauma, including episiotomies, and number of pregnancies that could cause pelvic trauma. When it comes to the medical comorbidities, the things that can lead to fecal incontinence are dementia, Parkinson's disease, multiple sclerosis, and diabetes. All of these conditions can lead to fecal incontinence in different manner. However, many times patients are not even aware when they start having fecal incontinence. There's multiple different medications that can affect our systems and lead to fecal incontinence. Important thing to mention is prior surgical history of hysterectomy, history of gallbladder surgery, or different kinds of anal surgery. I didn't mention it yet, but one of the things that we do is prolapse surgery, and multiple times we have patients who have rectocele, which is a bulging of rectum inside the vagina, and oftentimes that can lead to discomfort or fecal incontinence. So how do we treat fecal incontinence? There is no one simple answer to help with these conditions. The first thing, we start with things that we can modify, and those things often are our diet and bowel habits. Some of them are modification of food and beverage, and trying to write really careful diary of the things that can lead to possible incontinence. Caffeine can also be one of the offenders that affects fecal incontinence. Fiber, actually, patients with fecal incontinence often needs more fiber because fiber helps bulk up the stool, and therefore that leads to less incontinence. Regular bowel movements, adequate positioning during the bowel movements. I think a lot of you might have heard about squatty potty, but a lot of times squatty potty does help patients empty their bowels better and therefore prevents some of the fecal incontinence symptoms. The second thing to take attention to is skincare. It's important to know what kind of toilet paper are you using and how's your body reacting to it. Having ability to wash around anus, avoid products with perfumes or different deodorants, and then using cotton underwear. And then when we come to medications, different bulking agents. Oftentimes when we have fecal incontinence, our stools are loose. So we do need to bulk the stool, and so using the bulking agents. Sometimes we need to use antidiarrheal medications like Imodium, and they help us have more regular formed bowel movements. And then other times we have to restrain to different prescription medications to help us, to help our system reset and actually adjust. Okay, Niru.
Okay, thank you, Svetlana. Dr. Lozo, that was wonderful. A lot I didn't know, actually. Well, not a lot, but a couple things. Okay, so we do approach our patients with an integrated pelvic floor health approach. And what does that mean? That means when we first meet our patients, we spend a long time just getting their history, how their issues developed, and what they're feeling now. And starting from 20 years before and what's going on now. We do a detailed evaluation, a medical exam, where we're looking for skin changes. We're looking internally in the vagina. We're looking for muscle, how the pelvic floor muscles are, how strong or how weak. And we also do want to address any sexual concerns that people have. And each patient has different issues. We see, I think Brenda did say the different conditions that we see. So obviously not everyone comes to us with pelvic organ prolapse. Not everybody comes to us with overactive bladder. Not everyone comes to us with fecal incontinence. So, and some people come with the combination of different things. So each treatment plan is individualized for each patient. And we don't always only talk about surgery. There's a lot of conservative things, and that's actually what I mostly do in the practice, while the surgeons will do more of the surgical procedures. The non-surgical and conservative treatments is what I do. Okay, I'll just say a word about some of the conditions that we do see. And they can kind of present similarly, and it is really important to tease out what we can from what's going on so that we can treat it. One of the conditions we see very often is recurrent UTIs, urinary tract infections, and this can happen especially with menopausal, in the postmenopausal age women, because there's a lack of estrogen being produced. Therefore, the vaginal tissue at the urethra and in the vagina, there's a lot of dryness and the elasticity is lost. And if you're not having estrogen being produced, then it makes the tissue and the bladder susceptible to urinary tract infections and not being able to fight off the bacteria. So for that, we do really recommend using topical vaginal estrogen, which we can talk about in the Q&A. Another frequent condition we see is overactive bladder, and that can or cannot be accompanied by actual leakage of urine. So that's that condition where maybe sometimes you put the key in the doorknob and you just cannot hold it on your way to the toilet, or when you're in the bathroom and you're undoing your pants, cannot hold it, and you just have an accident. Or you feel like every 30 minutes you have to get up and go to the bathroom. And that's another aspect of overactive bladder. And we can talk about treatments. Some of them, I'll just say briefly, there's pelvic floor physical therapy, which can be very helpful for overactive bladder. We have medications for overactive bladder, and I'll talk later about some procedures that we have for overactive bladder. And yeah, that's, we'll get into that, some of that later. And I'll leave the painful bladder for Dr. Lozo to talk about.
I think, thank you, Nero. So one of the things that, overactive bladder, Nero really nicely explained something called OAB, which we often say, most of the commercials, when you see them on TV, when you have elderly ladies with a beautiful white hair floating, I usually say it's probably OAB, new medication. But important thing to mention is, besides overactive bladder or urinary urgency, there's different kind of incontinence called stress urinary incontinence. And I think my partners in Nero addressed it last time, but I just kind of want to remind everyone what the differences are and where the things are. Stress urinary incontinence is a leakage of urine with coughing, laughing, sneezing, any kind of physical maneuvers. And it is usually dependent on instability of the urethra. That, in contrast, is very different from overactive bladder, which is what happens when you have urgency, frequency, and you feel like you just can't make it to the bathroom. So I just kind of want to mention those two different aspects. Besides incontinence, we also deal with a painful bladder syndrome. There's multiple causes for painful bladder syndrome. In the past, it used to be well known as an IC or interstitial cystitis. And then over the years, we as a society, in a medical field society, evolved into a question of, well, it's not just inflammation of the bladder. It's actually painful bladder syndrome that can be due to multiple different factors. So in this state, we evaluate the pelvic floor muscles, we evaluate the bladder and bladder lining, and we evaluate the ways when the bladder is painful and what we can do to help assist that. I'm going to go to the next slide. So I'm going to start talking a little bit about office-based procedures that we do, and Nero and I will tag team on each other. In office, we offer an array of different treatment options that can really help our patients. Some of them are cystoscopy, intravesical Botox injection, urodynamics, percutaneous tibial nerve stimulation, or trigger point injections. I will start with cystourethropy and a Botox injection. So what is this and why do we do it? Oftentimes, patients come to our office complaining of different urinary symptoms. And a lot of times we start their treatment options very conservatively. We start with pelvic floor physical therapy. We start with a diet modification. And sometimes we have to start with medications. However, if there is anything suspicious that we would like to evaluate the bladder cavity better, we proceed with cystourethropy. During the cystourethropy, it's an office-based procedures when, as you can see here on the top of the picture, here, we have a patient who comes to our office. We place a numbing agent in the urethra and slowly insert small camera inside the bladder and fill the bladder with fluid. During this procedure, we look around, evaluate the bladder cavity, how much is it able to hold, what is the bladder lining looking like, is there any defects, any inflammatory changes, any stones, and then we proceed to evaluate urethra at the end of the procedure. Another aspect of cystourethropy that we do is a Botox injections. And all three of us physicians do a significant number of these injections on a weekly basis. This is because Botox is an excellent treatment option for urgency, frequency, overactive bladder. And so what happens is that patients come to our office, we have them sit in a room and we, what I often call, have them get a little bit of numbing agent and help their bladder calm down. So we often install the solution with lidocaine, which is a calming and numbing agent inside their bladder, and have them sit for 15-20 minutes with this solution. Following adequate numbing, we do the cystoscopy like I described before, but this time the cystoscope has a little needle that's connected to the syringe that has Botox, and we inject Botox in their bladder muscles. It usually is fairly well tolerated by majority of our patients. Patients go home the same day, and usually Botox takes 7 to 10 days to start working. Majority of our patients really prefer to have this done in an office because they're able to go home and relax the same day and then proceed with their regular activities the next day. I'm gonna have Miru go with urodynamics.
Okay, thanks. Urodynamics is a study that really looks at how your bladder functions, what the capacity of your bladder is, what you're feeling as the test is going on, and I'll explain the test and how it works in a second. And it looks at if you are going to be leaking any urine, either with the overactive bladder picture or the other kind of leaking that Dr. Lozo referred to, the stress incontinence. And the stress leaking is when you cough, like she said, cough or sneeze or bend down and you have a little spurt. So that we try to mimic in the office during the test. Or the other kind of leaking, that overactive bladder, sometimes as the bladder is getting filled with the water, the patient will feel that urgency and they won't be able to control it and they'll have a leak. So we're looking at all these things when we do the study. A lot of times women are already scheduled for some surgical procedure afterwards, and the physicians want to get this study to see what they're working with before they do the surgery, especially the issues of the leaking. And also another important thing is to see if the patient is retaining fluid and not being able to empty all of the fluid that we've put in. So what happens is that the patient will come in with a comfortably full bladder. They will empty. Dr. Lozo, do you have, can you do you can't see the mouse.
Well,
right.
Do this?
Yeah, right there. So the initial step is they will empty their bladder and then into a special beaker that is measuring how much and how fast they have emptied their bladder. And then I will take out any remaining, what we call post-residual volume in the bladder with the catheter. And then we start filling, once the bladder is empty, we will start filling the bladder slowly with some just plain sterile water. And as I'm filling the bladder, I'll ask questions, and again, to get a sense of what's what. What are you feeling at 100 milliliters of water? What are you feeling at 300 milliliters of water? Normal bladder capacity, just for reference, is between 400, 500 milliliters. So usually we don't even have to go up to 500 because that's a lot of water. So once we fill up to your, when I say you, I mean the patient, your capacity, then again, I'm going to be seeing the last time, coughing. Are you leaking? Okay, what about any contractions? Are you leaking at this point? All right, no. So then after you've filled your bladder, no more, you can't take any more, then you will empty all the fluid that we put in. So hopefully the input will equal the output. And if not, then we have to start thinking about why is the patient not emptying all the fluid that we put in. So yeah, it sounds complicated because it is a pretty thorough test, but it really is something that gives us a lot of information about how a person's bladder is functioning. Like I said, the question of retention, the question of leaking, the question of just sensation, decreased sensation, increased sensation. It gives a pretty good picture for the surgeons to know what's going on before they do any kind of surgery.
I will proceed with that. I just wanted to add a little thing that I usually tell my patients is that I say that, in cardiology, they usually have a cardiac stress test where you go walk on a treadmill and run on a treadmill. I think this is in urogynecology, our version of stress test. What we do is to try to figure out what is happening with your bladder, what is your capacity, where the things are and what you can tolerate. Okay, I'm gonna go with next one.
Oh, okay. I'll just say a quick brief word on this procedure. This is percutaneous tibial nerve stimulation, PTNS for short. And this is a third line treatment for overactive bladder. Again, urgency, frequency, incontinence. Also, it can help treat nocturia, which is when a person gets up many times during the night to void. So it is a 12-week session, and it's very similar to acupuncture, except that there is a stimulator that sends little pulses from your ankle, which is where the needle is placed, all the way up to your to the sacral area. And the science behind it is largely actually not quite understood, but there have been studies, and the efficacy is, Dr. Loza, what, 60, 70%? It really varies. From some women, they know they don't want to start any medications, or they know they don't want to do any Botox. And this is a non-pharmacological way to start and see if it helps. So it's a 12-week session. You come to the office, you sit just like this person is in the chair, you elevate the leg. We try to alternate sites. 1 week it's that foot, the other week it's the other side. And you sit there for 30 minutes while you feel these electrical pulses traveling from your foot. You don't necessarily feel them going all the way up there, but that's what's happening. And it does help for some people, but some people after the 6th session, they're like, yeah, no, I don't think I want to continue for the full 12. Some women love it. And after the 12th session, they will come for monthly maintenance sessions. So
I think what Nero just says, the big challenge, and I'm sorry for interrupting, the big challenge is being consistent on a weekly basis. And most of the time, if you see any improvements, they're going to happen after week 6 or 7. So the patience does pay off when it comes to this treatment option often. The part of it is, this is one of the treatment options with minimal side effects. So this is why our patients who have multiple medical comorbidities and multiple medications prefer this, because this is one of the few treatment options that really doesn't have side effect except the time, that patient needs to invest to come and see us. Okay. So trigger point injections, I'll give a little bit about trigger point injections. Trigger point injections is a well-known concept of placing either numbing agent or numbing agent and steroid into the muscles that can cause discomfort. Oftentimes we have patients who have different kind of pelvic floor discomfort syndromes, different pain symptoms, and different spasms. And sometimes we do have to use trigger point injections. In this case, what we often do, we can do, like I think this needle in this picture shows like pudendal nerve block. So patient would come to our office, we would help them clean their vaginal vault with some cleaning solution. And then I usually put a little bit of numbing gel to help with discomfort, and then insert the solution with lidocaine or marcaine, which is a numbing agent, and a little bit of steroid. Oftentimes, patients who respond well to the trigger point injections come in 1 or 2 weeks for repeat trigger point injections. And most of the times for some of the conditions, 2 or 3 trigger point injections sometimes can significantly help alleviate discomfort syndromes. Trigger point injections are well known in orthopedics, in different kind of muscle medicine science, but that's one of the things that we offer in our practice. I think I have done a number of them for hypertonic pelvic floor and something called levator muscle spasms, where patients who present to us have really hypertonic pelvic floor that they are not able to relax. And therefore, this hypertonic pelvic floor can lead to urgency, frequency, discomfort. Even though they try pelvic floor physical therapy, they're not even able to relax their pelvic floor or feel comfortable. So a series of trigger point injections sometimes helps them relax the pelvic floor. On the point of the pelvic floor injections, if the trigger point injections are working somehow, but patient desires a little bit stronger and more lasting effects, we're also able to do Botox injections in the pelvic floor. Botox, as majority of us would know, is a medication that helps relax the muscles. So if we inject Botox in the pelvic floor, it helps relax the muscles, so it prevents the spasms in the pelvic floor. And that's also one of the solutions that we offer.
Dr. Lozo, you might want to just say what's a trigger point? Why is it called a trigger point? Because I know that it's sometimes can be confusing.
So it's a point where there is a spasm of that muscle that you tried to do. Is that what you were thinking, Neru?
Yeah, but can you just go back to that other slide and then?
Okay.
Yeah, so there are certain areas where.
Well, there's certain areas of the areas that did have that have the spasms in the points, and then you want to try to inject those spastic points. So oftentimes the patient can say, I feel discomfort right here, or I feel discomfort right there. And that can actually, we're able to place it there. Yes.
Yeah, no, I think that's helpful.
Okay. And then, thank you, Neru. And then we here have our information for our telehealth or new patient visits. We do see patients in an array of different locations, including our main campus, Columbia, Fort Washington Avenue office. We see patients in Orangeburg. We see patients in a city on the 51st Street. And then I see the patients in our Scarsdale office. So this is our presentation so far. Okay. Sorry for the clicking about it. Okay, I see one question right now. So I'm gonna open that question. It says, do you have to come back for subsequent Botox injections, or is one treatment regimen all a patient needs? So Botox unfortunately wears off. And so Botox usually lasts 6 to 9 months. So majority of our patients who we do Botox for urgency and frequency come to our office every 6 to 9 months, and they're able actually to tell when the Botox is wearing off. And they often call our office and they say, I think Dr. Lozo, it's time to come see you again where we are. And sometimes if initial Botox, we start with 100 units of Botox, and if 100 units is not enough then we proceed and place higher number of units. But usually our standard is 100 units of Botox. And for overactive bladder, it does have a high success rate into 80%.
Great. I actually have a question about any of these procedures you're talking about. Let's talk about pain. Doing the procedure, how painful is it? Like on a scale from 1 to 10 on average?
So I think, Brenda, it's a very different for different patients. Okay. I think the first thing that we have to address is patients' comfort with the procedures, patients' pain levels and tolerance levels, and their ability to, sit in the office and kind of understand and convince themselves I'm okay doing this. That's the first thing. And so with our patients who have significant anxiety, fear of needles or the things, we actually do it in the operating room. We give the patient sedation and we take them to the operating room. However, majority of our patients, I would say solidly 80%, come to our office. We install solution with lidocaine that helps calm the bladder down and relax the bladder. And most of our patients say that was on the scale of, one being the no pain and 10 being the most pain, about 3 to 4.
That's not bad. Not bad. So I have a few questions. I know we do have another question, but are there any types of pelvic floor muscle strengthening to decrease fecal incontinence?
What's the question? Are there any kind of, I can't see it printed. I don't know if you're getting
No, this is my question.
Oh, okay.
Yeah. Are there any type of pelvic floor muscle strengthening exercises to decrease fecal incontinence?
Yeah, I'll just start by saying there is pelvic floor physical therapy that can help with the strengthening of the sphincter muscles. And then a lot of colorectal practitioners will use biofeedback combined with some aspect of the physical therapy, and that will kind of show you on a screen what's going on with the muscles. But Dr. Lozo, you can also talk about.
No, absolutely. So I think the big thing to figure out about muscle strength is there a muscle to be used?
Yeah.
And so that's the key when it comes to fecal incontinence, because majority of our incontinence is controlled by internal and external sphincter. And why the patients often develop these is that they had a sphincter tears in the childbirth, and then now 30, 40 years later, when they're in menopause and the muscles have significantly shrank down, now that lack of muscle strength or support that was supposed to be there is showing that it's not there. So the best thing when it comes to fecal incontinence is to have a detailed evaluation, see what's the muscle strength, what's the sphincter strength, and seeing how we can proceed from that standpoint.
I just want to say one more thing about the fecal incontinence. And this is true also for pelvic organ prolapse. You kind of need to know at what level you can, in terms of non-surgical, you can keep going for physical therapy and biofeedback, and it won't make that much of a difference if your condition is more advanced and does require some surgical.
I understand. Sure. So we have a question. Are these treatments covered by Medicare and other insurance? And what are the side effects of the treatments? Good question.
Dr. Lozo, I'll just take this one because I'm the one that's dealing a lot with the insurance issues. And I will say it depends. It's very variable. It depends on your insurance and what they are going to cover and what they're not going to cover. And sometimes you got to try different backdoor ways to get in there. So in my experience, the percutaneous tibial nerve stimulation has always been covered by Medicare. No problem with that one. Botox, if we do it in the OR, we don't have to deal with the payment. And if you're doing it in the office, that requires some extra, we try to get it covered, but that can take a little extra steps, but we do try to get that covered so that the patient has the option of whether they want to go into the OR and do the general anesthesia, if they want to just do it as an outpatient procedure in our office. And the
Side
trigger
effects.
injections are covered, as far as I know, and the cystoscopy that Dr. Lozo showed the image of, that's covered, and so is the urodynamics study that we talked about.
I
So
think
most
that
of them
another
are.
part of the question that was, is what are the side effects of the treatments? And so I think that oftentimes before we even start any treatment options, we talk about side effects. I always say we talk about the good, bad, and ugly, because we want you to know what is in there for the store. And the first thing that we start is that, for example, for the medications, multiple medications that we use for treatment of overactive bladder does have a side effect of dry mouth and constipation. And so then the question is, what's your baseline status of dry mouth and constipation and what you can handle? PTNS has a very small amount of side effects because it's a fairly just acupuncture needle, but it does require 30 minutes of your time every week. So the question is, do you have 30 minutes every week to come and see us? And if you have a good success, start noticing success about week 7 or 8. Botox is extremely effective for treatment of overactive bladder, but does have a side effect of urinary retention, which means that in a certain percentage of patients are not able to fully empty the bladder. And then when you're not fully able to empty the bladder, you had increased risk for urinary tract infections. Again, this is all in 5 to 7, sometimes 10%, depending on which studies do you read. It's a small numbers, but it does affect you if you're the one who is experiencing those symptoms. So I think all of us are very good about walking our patients through side effects of the treatment and seeing what side effects they could handle and cannot handle.
Because we do have another question, I just wanted to put a little plug in and mention, Nero, you had talked about recurrent UTIs with menopause, and we're actually hosting a menopause event on November 3rd at 6 p.m. with one of the Columbia medical physicians. So yeah, and folks, you'll see that in the end slide, and probably by Monday, I'll send a follow-up email that include a lot of information, including those events. The question is, does PT work well for overactive bladder?
I can start, and Dr. Lozo, please pitch in. Again, I will go back to what I was saying earlier. You kind of want to know like where you are on the scale of overactive bladder. What degree are we dealing with? And also, what if you want to start with PT, and if it's not that effective, or do you want to try other treatments, or you want to just stick with PT? So let's say that your overactive bladder is it's not something that you would really go straight to Botox for. Sometimes you just need a little strengthening. And what I tell patients is that it does a whole reorientation of your system, your genitourinary system, and it kind of helps you take control of your bladder versus your bladder controlling you. And it's helpful for people to really get an understanding of what the anatomy is and how to it's not just Kegeling. I thought that before I started working here. And then even the Kegels, it's actually quite nuanced, and it's not just a question of like squeezing, tightening those muscles. You don't want to use your abdominal muscles, and you don't want to use your rectal. You want to use your vaginal wall muscles. And that takes time to kind of understand how that works. So PT is great for people who are motivated. They know they want to start there. They're not interested in starting a pharmacological agent. They don't want to do the Botox. It's great. Now, in terms of insurance, some places take it, most places don't. So it is an investment. And it's another time commitment. It's like PT for your shoulder or your knee or your ankle. You go twice a week. It's done by women, and the more you're able to do stuff at home, the better your outcome will be. Some women really love it.
So I think the important thing to also mention is when I often talk to my patients is the question of, we often think that our brain and our bladder are connected, and they're not. When, you know what I mean? And the part of it is that if I tell you to squeeze, you often push. If I tell you to push, you often squeeze. And so the part of it is having a pelvic floor physical therapist evaluate the actions, see what is your pelvic floor like, and how you can hopefully help delay the urgency is very, very helpful. Even if you have severe incontinence and you need additional treatments, I often find that additional treatments are even more successful when you had a few sessions of PT well. Now, I see patients in Scarsdale office, and in Scarsdale White Plains area, there are multiple pelvic floor physical therapists that actually take insurance. And so I think from that standpoint, we are a little bit luckier than patients in a city, because our patients in Scarsdale or White Plains or Westchester, there's an array of pelvic floor physical therapists that are more insurance friendly. So I think that's something that we definitely can look into.
Great. Another question. Does doing the Botox treatment help facilitate, accelerate the effectiveness of PT? Or since Botox blocks nerve reaction, does Botox inhibit PT effectiveness?
So actually, the Botox infects the nerves in the wall. It affects the muscles in the wall of the bladder, but not the pelvic floor. So that's like when we do cystoscopy and do the Botox injections, those injections are going into the trusor muscle of the bladder. But that, is different muscles that you're squeezing than the muscles that you are controlling when you do the pelvic floor physical therapy. So those are two separate things and it does help. Like patients who do PT in collaboration with the Botox are very happy.
I also just want to tell the person who asked this, the use of Botox is for the overactive bladder, and then so also for the nerve. I don't know if the person is asking, since the Botox treatment facilitates the effectiveness, it's the Dr. Loza, the blocking the nerve reaction, like the trigger point, is that the question?
Yeah, I think that if we're gonna do the pelvic floor muscles, and that's a different kind of story, but you still have like overactive bladder, overactive muscles, so you would still be able to do some squeezing from that standpoint.
Yeah. Okay.
One attendee is saying, I have overactive bladder and just had the cystoscope showing I have a lot of cysts in the bladder. How do you treat these, and will they go away?
So when we talk about cysts in a bladder, there's a lot of different ways that what the cysts are. And so are they diverticulums, so that your bladder is stretching, or are they cystitis cystica, which that's probably what it is. And cystitis cystica is often inflammatory condition. So oftentimes we need to use different medications, or we need to change the diet and go on a painful bladder diet, which is low acidity, low caffeine, low bladder irritant diet that can help this condition better. But we need to know exactly what the cysts are, because just using the word cyst in a bladder can sometimes be very challenging.
Okay. We have a question. Would you share the physical therapy centers in Westchester County, please?
Yes, so there is from the New York Presbyterian has two different pelvic floor physical therapists. One of them is in 700 White Plains Road, and the second one is 356 White Plains Road. So those are the two that are New York Presbyterian centers. Both of the therapists that are there are excellent. However, their wait list is about 5 to 6 weeks at this point. And then there are few private practitioners that I would have to pull the information in, and I can send that to Brenda. So she has that available.
Great, good. Any other questions, folks?
Oh, there's another.
Yeah. What non-surgical treatments help with bowel evacuation and motility? It seems like the ones you were talking about are about for bladder.
So I think when it comes to the bowel evacuation and motility, we need to figure out first the reasoning. Why do we have bowel evacuation problems and motility? We do not deal with a bowel motility concerns. So that would be the gastroenterologist who would help, determine what is the cause of mobility concerns. And there's often different inflammatory bowel conditions, ulcerative colitis, IC, IBS. Those are the things when it comes to the motility that need to be stabilized before we can do anything. With the bowel evacuation concerns is that why is one having issues with bowel evacuation? Is the question of what medical conditions do they have? What medications do they use? How long has this been happening for? And is there anything new that they started that can provoke this condition? Oftentimes when we see it is patients who are getting new onset of constipation and discomfort due to different conditions. Just a change in acute status. For example, if you are a patient who is used to walking 1 or 2 miles a day, and then you, let's say, have a knee replacement and you can't walk and you have been using some even ibuprofen and Tylenol, your bowels are going to change. Your bowels are going to see the things. So we need to kind of figure out what's the cause of it. Oftentimes we look at the anatomical structures. Is there any rectocele, which is a bulging of the rectum inside the vagina that can be obstructing the evacuation? Do you have a rectal prolapse and is your rectum coming out and that's causing discomfort? Are there any difficulties with sitting down and comfortably emptying the bowels? Let's say, you have a back surgery. Can you comfortably sit on a toilet and have a bowel movement? So all of these things really affect how one has their urinary and bowel habits. And so it is often an array of multiple providers, multiple conditions, coming to bridge one solution.
Folks, we do have a couple of minutes left. If anyone else has questions, please shoot them out there. And Dr. Lozo and Nero, you are both in the Scarsdale office, is that right?
I'm the one who goes to the Scarsdale office.
Okay.
Yeah, and I'm there every Thursday. Thursday is my usually day in the Scarsdale office.
And folks, again, I just want to remind everyone, at the end, we'll have an end slide that will have those different locations. And when I send the follow-up email, I will include it again so you can contact our speakers.
Okay. I think,
Anybody else?
Go ahead, Brennan, sorry.
No, any other questions? Nope, I think that's it.
Okay.
I want to thank you all for joining us tonight. Thank you, Dr. Loza. Thank you, Nero, so much. Wonderful information. A lot of information that I've not heard of before. So really good, great stuff. I also want to thank our guests for watching tonight and my colleague, Chris, for handling the back end of the website. Thank you all. And folks, remember, if you need to contact the Kensington, we're here. You'll see the phone number up on the slide. And remember, we've got that menopause event on November 3rd with, again, our wonderful folks from Columbia. So thank you all. Have a great evening.
Thank you. Have a good one,
Thank
everyone.
you.
Bye-bye.
Thanks for having us.
Bye-bye.
Bye.